is May 6th, House Healthcare. And we are going to walk through all of our language changes on S-126 and see all the wonderful work that Jen has been working on this weekend. So thank you.
All right. Good afternoon, Jen Carby from the Office of Legislative Counsel. So you should all have access to what is draft 1.3. So 1.2 was posted and sent to members earlier. It was unedited. So 1.3 is just the edited version, nothing substantive. The editors made some grammatical corrections, asked about a couple of very minor things. So that is what 1.3 is. All right, so I will put it up on the screen and we can walk through. There are a few colors in it. So before we start, let me explain why. I tried really hard not to use multiple colors, but it didn't work. So yellow is, as I usually do, these are changes based largely on what we discussed, or occasionally they were just sort of cleanup changes that seem to make sense in context. Green is language that was brought to or requested of me from outside, or that people have not really looked at or had an opportunity to consider. And most of those, I mean, most or all of those should have brackets. There are attribution brackets in some cases where language came from particular witnesses' written testimony. And then blue is stuff that I particularly wanted to flag to ask you all about. So this is our strike all amendment, starts out with the purpose of the act and goals. The purpose of this act is to, and now it says, achieve transformation of and structural changes to Vermont's healthcare system. In enacting this legislation, the General Assembly intends to advance the following goals. First is improvements in health outcomes. We moved population health for number 4 up here. So improvements in health outcomes, population health, quality of care, and regional access to services. An integrated system of care with robust care coordination and increased investments in primary care, home health care, and long-term care. Stabilizing healthcare providers. We changed reducing to controlling commercial health insurance premiums, and managing hospital costs based on the total cost of care, beginning with reference-based pricing, thus saying continue on to global hospital budgets, which maybe should come out since those doesn't have the report rates for that. So let me put brackets on that. Then we have evaluating progress in achieving system transformation and structural changes by creating and applying standardized accountability metrics. And 5, establishing a healthcare system that will attract and retain high-quality healthcare professionals to practice in Vermont. And then Representative Goldman had talked about wanting some additional workforce language. So what she sent me was, and that supports, develops, and preserves the dignity of Vermont's healthcare workforce. Although she doesn't necessarily know this is where I put it, but this is where I put it.
Works for me.
So you want me to stop there for discussion on section 1?
Any discussion? Yeah, Brian.
Yeah, I was taking notes. I didn't think you were gonna have a chance to discuss so fast.
I mean, it's the chair.
So many colors in so many pages. Let's
So much.
Section by section. I think it makes sense. I'll stop writing the note and just say what I was trying to write. That when it's, I know that it might be hard to reduce premiums, but when it says controlling, when I think about that, I feel like we already control them.
I kind of thought it as we said.
Yeah.
Just say,
So, I mean, it's not clear. I think what we're trying to do is like keep them from going up at a disproportionate rate to the income people or something like that. Like,
controlling the growth.
yes, there you go.
well,
Well, we already do that though.
no, because
We're supposed to do that.
well, yeah, but we're also in
These are your
this
goals.
bill
These are your
trying
goals that you're doing.
reduce.
Right. So these are the goals that you are doing and enacting this, advancing and enacting this legislation.
Especially.
The increase and the rate of increase. Yes, reducing the rate of increase. Well, yeah, but if we put reducing the rate of increase, that means that we're expecting increases. And originally this bill, and we have a lot of things in this bill that are getting to reducing and right sizing. So
I have an idea, but it might be a little weird. What if we say reimagining? Because then it leaves the door open for a new way.
reimagining health.
Yeah, like,
Virtual
for
health
example,
insurance.
someday they could be replaced by taxes and it could be a publicly financed, you know?
I think reducing the rate of increase
I tried.
includes reducing. Reducing is a form of reducing the rate of increase.
But if we're reducing, we're not increasing, we're reducing.
Decrease.
You're decreasing.
It could also be interpreted as reducing them in the practice of using them in general.
Managing is
a step towards the
different from controlling.
Control.
That's what it
That's what
says.
it says. I think,
That's his point.
I actually think controlling is really good.
Could we say controlling increases?
Or just
about
controlling the
controlling?
cost of, what if, do you just say
Increase.
controlling the cost?
Yes, controlling the cost of.
Controlling the cost of health insurance premium cost.
Although what we're missing here is cost sharing. Like, why would we only try to like manage the premium? Shouldn't we also be trying to eliminate or reduce the cost sharing mechanisms for people? Or
Right, so what if we just say controlling the cost of health insurance?
yes,
Costs
there we
of
go.
health insurance?
Yes.
Costs
Okay.
total?
It doesn't have to be bad for the insurance companies. It could be that they're helping them have a more sustainable practice.
Okay, and I'm just putting this out here. I don't want to go into the weeds on language on things. I mean, we could,
So we do.
but we want to get this, we need to get this out. It has to be out.
Right. Section 2. Hospital budgets and payment reform. This is a list of the board's duties. We added reference-based pricing and did not change that. I wasn't quite sure where you landed on, but not later than 2027, so I just wanted to pause there. I didn't change it because I didn't recall there being interest in changing it on the committee, although I do think there was from some of the parties doing the work.
I think we had robust discussion about it.
Can you give me an overview of who was pro this timeline, who was con this timeline?
The Green Mountain Care Board was
They
like,
concerned about a date certain.
yeah, they were concerned about a date certain.
And I think legislators have wanted to move, as Senator Lyons would say, with alacrity.
Alacrity?
Around the room, yes.
And elected. Okay, and they can always come back to us. They can always come back to us and say in 2026 and say, this is not practicable and we can change it.
Great.
Are you okay, Leslie, with that?
I'm just confused about beginning of the year, end of the year. 2027 is a year.
Yes, it does give a bit of flexibility in there.
So we could be anywhere in that year. Okay.
All right, then we have, took out the language about the hospital global hospital budgets. Because you put that into a report, but you're not having them do it. All of that came out. Section 3, reference-based pricing, it's rate setting, and so there was this one piece you wanted to remove on page 5. Under existing law about access to primary care health services, and you wanted to take out for underserved individual populations and areas, so it is. And it's bold, even though it's being struck, because it's being struck from the bill, or from the law, and that's new.
I can't remember where, and I looked through it, where we put the new language for equity.
The piece from Representative Donahue, it's in the plan.
Okay,
Strategy.
Right?
It's in the strategy, not the
Strategic
plan.
plan?
I thought it was a
No, strategic plan. All right, so then we get to reference-based pricing, lots of changes here. So the board shall establish reference-based prices that represent, and here I use the board's construct to have that represent the maximum amounts that hospitals, and the board had suggested, but I don't know that there had been a decision made, so I put it in green. Other healthcare professionals shall accept as payment in full for items provided and services delivered in Vermont. And I do think there may have been a bit more to the board's language that I did not include. Let me see if I can tell you what and what. No, I guess it's not. There, that is what they had. There's something somewhere that I only took a piece of. So I think the question for you on this is, do you want it to say other healthcare professionals? I think it makes sense because later on you give them at least the authority to do it for other healthcare professionals, but I wanted to check to see if there's any reason not to put that in there.
Be any reason not to put it in.
All right, took out the purpose language, because the board's proposal took that out, and I wasn't sure if you were, I think we had talked about taking some of this out because it was just confusing or it didn't seem like an accurate representation. I can't remember if you literally looked. You had in your conversation the other day, we were talking about the purposes of reference-based pricing are to contain costs and move healthcare professionals toward a site-neutral pricing structure while also allowing the board to differentiate prices among healthcare professionals as appropriate. I think you've heard in some cases that site-neutral is not an accurate description of what reference-based pricing does, so it didn't seem like an appropriate thing to put in here. So I just struck it and moved on to the board's consultation. All okay with that? All right, so the board shall, kept in here, consult with health insurers, hospitals, other healthcare professionals as applicable, the Office of the Healthcare Advocate, and the Agency of Human Services. And now I added it up here in developing reference-based prices pursuant to this subsection E, and then including on ways to approach, on ways to achieve all payer alignment on design and implementation of reference-based pricing. So we're not having them consult specifically on ways to approach reference-based pricing in an effort to achieve all payer alignment, but that is a piece of it. This fit more with what folks were thinking. Great. The board shall implement reference-based pricing. So this is where I moved the balance billing piece up. The board shall implement reference-based pricing in a manner that does not allow, and I think we talked about hospitals, but it's also healthcare professionals. So maybe we just go with healthcare professionals, which includes hospitals in the definitions in the Green Mountain Care Board chapter. So that does not allow somebody to charge or collect from patients, and I know the insurers had wanted to add, or health insurers, any amount in excess of the reference-based amount established by the board, and the board would strike for the item provided or service delivered. So lots of questions in there.
Okay, Brian?
I think it would be good if it said something like, does not allow providers to charge or collect from patients or payers, because then we're using the three terms commonly used, but I don't know if that's legally.
And they're not consistent with the terms used in this chapter.
Oh, okay.
So want to make sure our language.
What was it? So health insurer and healthcare professional would be the consistent term?
Yes.
Okay, well, I would say that does not allow healthcare professionals to charge or collect from patients or health insurers. That would be my opinion.
Yeah, that would be
Okay.
mine. And getting rid of hospitals, they're covered under
Yeah.
healthcare.
They're covered under it. I just wanted to make sure depending on what you had decided about healthcare professionals in the first one. Okay,
I think it's different earlier because we're trying to, because of the way it's worded, but here, because it comes later, I think this is.
great. Reference-based prices established pursuant to this subsection E shall be based on a percentage of the Medicare reimbursement rate. And there was some, Blue Cross had proposed saying, and methodologies. Green Mountain Care Board had concerns about that. So flagged it here for you. For the same or similar item or service, or on another benchmark as appropriate, because you did hear both that there are some for which Medicare is not appropriate, or that Medicare may not make sense. I'm sorry, some that aren't included in Medicare, and others that don't make sense for Medicare. So, and then provided that, and I changed after to if the board establishes initial prices that are referenced to Medicare, the board may opt to update them in the future based on a reasonable rate of growth that is separate from Medicare rates, such as the Medicare Economic Index measure of inflation, in order to provide predictability and consistency for healthcare professionals and payers, and to protect against federal funding pressures that may impact Medicare rates in an unpredictable manner. The board, and then I added, The board may also reference other payment or pricing systems where appropriate. And I said, if we keep this, maybe delete another benchmark up here, or we could leave it in both places.
I just have a question. If we say, if the board establishes initial prices that are referenced to Medicare, then the board can update them. Are we excluding their ability to update ones that are not referenced to Medicare using another
I don't
benchmark?
I don't think so. I might have to, it's a good question, and I have to think about it a little bit. My point was just that I didn't want it to sound like they had to establish initial prices that are referenced to Medicare. So maybe just not initial, maybe if the board establishes prices that are referenced to Medicare.
Can we have them
What about
do
just
it
not
at any
Medicare?
time, including in the beginning? Not just initially?
Well, I would probably take out initial and then maybe, and maybe at the end, we say the board may also reference, and update other payment or pricing systems where appropriate.
Yeah. I'm just afraid with this language that the board will never be able to update.
That wasn't the point, and I do tell them later to, revisit as part of the hospital budget process.
Okay.
Hospital.
My only concern is if there are services that don't have a reference to Medicare, that we would need another benchmark or to allow that flexibility. Does it hurt anything to leave or another benchmark in?
I don't think so. And especially as we're saying, may reference and update.
You're talking about the yellow language?
Yeah,
Yeah, that has to be in there.
Well, because we have the language down in the green at the bottom says they can reference other payment or pricing systems where appropriate. That's a different benchmark.
Oh.
Um,
So
but I think it's fine to leave it in both and probably may help, doesn't hurt.
yeah.
Okay.
would the board over in the corner, could the board remind us why, other methodologies you don't want in there, which Blue Cross Blue Shield of Vermont does want in there?
For the record, Diane Ledford, Green Mountain Care Board, I'm trying to recall the testimony on things that are not maybe in Medicare, like, I don't know, prenatal care or something that there could be a charge that we wouldn't be able to find a Medicare reference.
That part, yes, I think the methodologies,
It's the methodologies part. I
so
said,
the board in their written testimony said they did not support the recommendation for methodologies because Medicare methodologies differ across types of hospitals, which could create unanticipated confusion and unnecessarily complicate the pricing methodology. And I don't know if the hospitals are able to shed any light on differing Medicare methodologies across hospitals.
Yeah, I'm reading from that, so it's the question, just. I think we want to keep open. Their benchmarks besides Medicare.
That, yes, but the methodologies, is it based on a percentage of the Medicare reimbursement rate and methodologies or not and methodologies? And then also the additional benchmark.
I think that what Blue Cross Blue Shield was trying to say with the methodology piece was that it already includes acuity and other things, and you wanted to capture that there. Is that right?
Or teach up with Blue Cross. Yeah, also, because my understanding is that Medicare uses outpatient groupers, where they group groups of codes together and then bill for or pay for all those codes together in one rate. And so that's the methodology piece I think I was trying to capture in that recommendation.
could we say something like, and where appropriate, other Medicare methodologies?
I feel like Medicare reimbursement covers it. methodology.
Reimbursement rate, do you think reimbursement rate captures it? Because it'd be like a DRG rate or something.
I just worry, I don't want us to to necessarily be tied to the methodology piece.
Daisy?
I'm gonna suggest that we strike and methodologies because I'm going back to when we first took this up, remembering to keep it broad so that as stakeholders implement this, there's a bit of flexibility for them to adjust it as needed.
Yeah.
And I think Medicare reimbursement rate could include that, as Devin said.
And I also think by adding the language or on another benchmark as appropriate, that gives them latitude to be able to use more appropriate methodologies, if so be it. Does that make sense? Brian?
Just a question that should be clear. Does the language at the end that Green Mountain Care Board recommend, does that language provide the protection we would need? Because it says here, like right before in a sentence, that the board may opt to update prices based on a rate of growth that's separate. And then there's more language, but it says to protect against federal funding pressures that may impact Medicare rates. But like if Medicare is completely undermined, would that final sentence give them the ability to use? Okay, great. That's all I want to make sure there's insurance. No pun intended. Yeah.
Yes, I will modify it to say something like the board may also reference to and update based on other payment or pricing systems where appropriate.
Yeah, I think that would be great.
Okay, so we're striking in methodologies
Striking methodologies,
and we're keeping the yellow language
we are keeping
and we
the
are,
language, we are striking out the word initial prices.
yeah,
And then we are adding a little language after reference on line 18.
yes. And, okay.
All right, on to page.
1/6 through.
Exactly. Okay, and then specifically in establishing reference-based prices for a hospital pursuant to this subsection E, the board, and the language as it came to you was shall, the board wanted may, consider the composition of the community served by the hospital, including the health of the population, demographic characteristics, acuity, payer mix, labor costs, social risk factors, and other factors that may affect the cost of providing care in the hospital service area. And then we move from somewhere else, as well as the hospital's role in Vermont's healthcare system.
Go ahead, Lori.
I think it should be shall, because I think those are really important things that are different amongst hospitals and areas. So I guess I have a question, if you don't mind, for Diane, for the board. Why did you want it may?
You should recommend, Diane, you want me to say it every time?
No, no. When we say the board, it's Diane Lanfear.
I'm looking at, we did make the recommendation, it's Jen, we're on page 8 at the top there. Yeah, we did recommend may. Now, do I know the full extent of the reason? But I think it gave us the leeway instead of the shall.
I will just point out that shall consider doesn't mean they have to actually do anything with it. They just have to consider.
What about better? The board better consider.
Grammatically speaking,
Okay.
add better.
I think I said at the start of this bill, I want more shalls than may.
All right.
But shall consider has the same meaning
Mike.
as I'll take that under advisement.
Sometimes, Madam Chair and Committee, that the shall, like, we don't legally maybe know where like that line ends and shall consider the communities or things that, may consider, at least gives us some leeway of taking things in stride.
I have deep trust in the board that they shall take those things into consideration.
Even if slightly, so.
I don't think that it's in the board's best interest to not.
Or the people's.
All right, then we have other types of reference-based pricing. So this says, oh no, I guess this is not different. The board shall begin implementing reference-based pricing as soon as practicable, but not later than hospital fiscal year 2027 by establishing the max. So I guess this is hospital fiscal year 2027. Maybe we should be consistent with that language throughout. Let me just add that in and tell myself to do it throughout. I don't know how many more times I can go.
You okay if we crack the window a little bit?
It's cracked.
It is
It
cracked.
needs to be a ravine.
You could do the other window and get a little,
Get a little less.
Crack the door and create a gap in the window.
anyway.
You wanna open the door a little?
That's why we just opened both doors and start out.
Nobody fall
I hope a bird better not fly in.
Papers, okay.
Huh?
So board shall begin implementing reference-based pricing as soon as practicable, but not later than hospital fiscal year 2027 by, and again, using this consistent language, establishing the maximum amounts that Vermont hospitals shall accept as payment in full for items and services. And then the board had said covered by a plan offered or administered by a health insurer. And I wasn't sure if being that specific started to get us. I just wasn't sure if that was necessary. And maybe it's necessary so that it's clear we're not talking about Medicaid or Medicare. And I suppose. Sorry.
Or cash.
Well, that's what I was just thinking, but it's the maximum amounts.
Max they can charge.
Well, it's the max they can accept. I want to be careful about charge because they charge on one list and pay on another. So I'm putting it out there to say, I'm not sure if this makes sense or not. I sort of feel like it does, but I don't want it to hamstring us.
Doesn't this basically say if somebody's self-pay or?
Again, it's the maximum amounts that they shall accept as payment in full. So they can always take less from a cash pay, from a self-pay person.
No, I'm talking about by putting in this language covered by a plan offered or administered by health insurance, couldn't a hospital then say that the maximum amount is only for health insurances and what people can pay if they have health insurance? Wouldn't this allow them to then charge a higher amount to say self-pay?
I mean, to the same extent they do now, but I don't know that they have the incentive to charge self-pay people
I
a
don't,
lot, or they probably won't receive it.
I just don't understand why it has to be in there. I don't,
I'm not.
what it's trying to accomplish.
I mean, we had the language previously about health insurers paying. Now this is plans offered or administered by a health insurer. So I think it may still be trying to. I'm not sure. I don't want to speak to what it is or isn't doing. I don't know. I guess what I don't know is the extent to which this is not helpful in helping us be able to capture self-funding.
Is there language suggestion? Was that submitted prior to us flipping things around?
It's part, I mean, in the same, same draft.
Okay.
So this is part of their markup that made the flip.
It did make the flip from
From insurers
paying
to the hospitals accepting, yes.
Eli, did you?
Eli Hoggett, Agency of Human Services. We would greatly prefer to explicitly exclude Medicaid from this section. And as far as changing the language around, then that would be our recommendation, is regardless of whether you land at health insurer or if you flip it to the charge that a provider can, the maximum that a provider could charge to please exclude Medicaid.
I think Medicaid is already excluded by the definition of health insurer for the chapter. Um,
But if we're flipping it too.
I mean, I think you could remove the covered by a plan offered or administered by a health insurer and just say something at the end of, for, for item, we could say provided, for items provided and services delivered, and maybe delivered to individuals in this state, provided this shall not apply to patients who are covered by Medicare or Medicaid. Because we know we can't do either of those, and, or unless permitted under federal law or something that way, if we get a waiver that allows it.
I'm sorry, I'm very confused. Are we back to the discussion? Is this the discussion around, can you charge different people different amounts for the exact same service? Not taking into account contractual, not taking into account like.
No, we're really talking about who we are being specific to with this language. Which patients are we talking about? Are we talking about people just with a plan offered or administered by a health insurer, or
I thought we were talking about everyone.
well, except we know we can't do, so AHS does Medicaid, that's why separately, not the way the board sets it, that's why Eli is mentioning specifically carving out Medicaid. We know we can't do Medicare unless we were to get a waiver that allowed us to include Medicare. So now we're sort of back to health insurance and the sort of broader self-funded and commercially insured. And my question is whether, if we're talking about a plan that is offered or administered by a health insurer, we start to wander ourselves into territory that gives us less control than we want. And I see the.
Yes, I see the
Advocates.
advocate. You,
I think it is cleaner to remove the green language. If we can't understand exactly what it's trying to get at, how would we expect anybody else to? I guess I will say that I initially understood it to try and focus on like medically necessary, like areas of service, like massage therapy or something that is not covered by insurance. But I don't think that's what it was doing. So
Yeah, that's a great question too. Is it just for covered services? That is confusing. Okay, let's take it out.
Yes, that makes sense to take it out.
And then, but then are people okay with,
is that what they're trying to get at by covered by?
I don't think so. But I don't,
Areas of service instead of individual service.
yeah, so I'm gonna suggest that we take that out, the green out.
Mhm.
But I think it may also make sense to specifically carve out
Covered.
Medicare and Medicaid.
Okay,
And I don't know if we want something around unless, permitted by federal law or waivers of federal law, or something like that. So that if we were to try to wrap it into something larger, we could, or if that would just need to be its own legislative conversation for another day.
shouldn't we also be carving out and putting the word covered somewhere in here? Because, I mean, let's think about a hospital. We don't want the Green Mountain Board to tell a hospital how much they must, the maximum amount they can charge for, say, hypothetically, a neck lift.
A what? Wait, a what?
A
A what?
cosmetic or non-covered.
A neck. Neck.
But why would you not? I mean, they might
Because it
choose to, but
But if it's an elective procedure, the board has absolutely no. Why would we want the board setting the maximum amount somebody can pay for, or like a massage therapist or medically necessary? I'm thinking, shouldn't we have something in there that it's medically necessary?
I don't know. That feels like it's
I have a
a
concern.
conversation. I think there could definitely be things that are not medically necessary, but would be covered by insurance,
That's why I'm saying.
Medically necessary.
right?
Well, is there a definition?
And of course, who defines covered? Because there are things that are
Right.
not covered.
Seems like that's introducing unnecessary complication.
Yeah, I don't
All
think we
right,
should.
maybe I'm not gonna get into it.
One of my concerns, for example, is what happens if. I think we might already be going down this path, actually, if you look at the Federal Health and Human Services recent policy briefs and stuff, but basically. What if they declare that gender affirming healthcare is not medically necessary, and then. Then we're not controlling the cost of that when we're still providing it here, which is why I think we need to leave the
Okay.
medically necessary part. That's an example
leave it.
of something that is very
We'll leave it.
real that can affect people's lives.
Jen,
Yep.
I'm reading this section like it's just saying that the board will have basically develop from the hospitals a pricing sheet for reference-based pricing. Is that not what this section is saying?
I mean, I think, yes, they are establishing the prices that are based on a percentage of something, some reference. I think, I mean, whether it's a different pricing sheet or how it's actually implemented, I don't know. But yeah, I think that's the point, is that they are setting the prices.
Or the maximum,
Right.
Yeah.
maximum the price could be.
I'm just like, why would we take that out? Like, we can't do
Take what out?
the whole section. I thought that was on the table.
No,
to
no,
keep the
we're talking
section.
about
Just the
bringing the green, which is why I don't understand why the green even needs to be in there.
Because it's.
Yeah, I'd like to cut the green. Can we cut the green?
Yeah,
What do you?
but I will carve out, carve out Medicaid and Medicare. And just stop there. Okay. Okay. And then after initial implementation, the board shall review the reference-based prices for each hospital annually as part of the hospital budget review process in statute.
Great.
Okay, so here's the balance billing that I moved, so just a little note on that. The board, in collaboration with DFR, shall monitor the implementation of reference-based pricing to ensure that, and so this had said, ensure that any decreased prices paid to hospitals result in commensurate decreases in health insurance premiums. There was interest in removing commensurate, so I just reworked it a little bit. Tell me what you think. To ensure that any decreases in amounts paid to hospitals also result in decreases in health insurance premiums. They're not as tied together, but just like we went down on one side, make sure that we went down something on the other. And the board would post its findings on the alignment between price decreases and premium decreases annually on its website. I feel like that still works. And number 4, the board shall identify factors that would necessitate terminating, and we talked about, or modifying the use of reference-based pricing in one or more hospitals, such as, and we talked about adding a measurable reduction in access to or quality of care. Then we have the Green Mountain Care Board, in consultation with the Agency of Human Services and the Comprehensive Primary Health Care Steering Committee established later in this bill, pursuant to language that the chair put forward, so you'll see that later, may implement reference-based prices for services delivered outside a hospital, such as primary care services, and may increase or decrease the percentage of Medicare or another benchmark as appropriate. First, to enhance access to primary care, and later for alignment with the statewide healthcare delivery strategic plan established pursuant to section 94.3 of this title. Once established, and then new language, the board may consider establishing reference-based pricing for services delivered outside a hospital by setting minimum amounts that health insurers must pay for the purpose of prioritizing access to high-quality healthcare services in settings that are appropriate to patients' needs in order to contain costs and improve patient outcomes. This is me trying to put the right care at the right time in the right setting into legislative language. And I think we have had, I've only barely looked at it, but an alternative proposal on this, I think, from stakeholders. I don't know if you want to hear about that or not on this number 5.
On the
From the medical,
yellow or the green?
I think number 5, the whole thing.
Number 5.
Yes, from Medical Society and by state.
Would the The Medical Society hasn't gotten to speak yet. How about the Medical Society?
Hi, Jessica Barnard with the Vermont Medical Society. Thank you. We were, I think, trying to stick with the same intent of the yellow language in this section. Our concern was that by state and raised, and we had supported a couple of days ago when we were in here on markup, the concept that when you're talking about hospitals, Elizabeth, and switching to the amount hospitals can charge, so that it's then everybody paying would pay the same amount. But for all the other providers, including primary care, there are many different providers. It really should be talking about the amounts that insurers pay rather than requiring sort of a consistent charge from the way this would be implemented on the provider and payer side. So we just wanted to make it clear. I suggested some language, kind of condensing this language, that we're not talking about two separate things here, because in 5 you're saying GMCB and institution may implement reference-based pricing, and then down below, it may consider establishing it by setting the minimum amounts that health insurers must pay. We just wanted to kind of take that concept of really what you're talking about with the amount that is paid is embedded in this whole paragraph. So saying may implement reference-based pricing on lines 14 and 15 by establishing the minimum amounts that health insurers must pay. Just to make sure we're clear that this is, if you're talking about non-hospital providers, it's using this different methodology than you're using for hospitals, so that was the language I just sent over to Jen. I will say also, I want to be careful now that the committee has talked about in the paragraphs above in this section, going in hospital healthcare providers, that we're not also confusing what methodology can be used for non-hospital based healthcare providers. If that makes sense, where those things, you also made changes in the paragraph about healthcare providers, not just hospitals. And I think like on page 7, you're saying the board shall implement that manner. It does not allow, sorry, that's about the charging, that's okay. It's the paragraph above E1A on page 6, you changed from hospital so that it's may set reference-based pricing that establishes the maximum amounts healthcare professionals may accept as payment. So I actually think if you're changing that for professionals, you may be setting up a conflict with this later paragraph about non-hospital-based healthcare providers.
Another hand over there.
So maybe what makes sense,
One sec, let's let Jen think.
maybe what makes sense would be to, in 1A here, take out the other healthcare professionals, but have a second sentence that kind of reflects that concept from later on about setting minimum amounts that health insurers would pay for non-hospital services or services delivered outside a hospital. So that we're sort of setting up that separate construct
Okay,
from the outset. Does that work for that side?
what you were gonna say, Mary?
I was just going to, sorry, Mary Kay Bowman, by State Primary Care. I was gonna add that FQHCs have a minimum payment amounts that's set in federal law, and so the idea that we could get caught in some sort of maximum charge that could potentially conflict with federal minimums. It's cleaner to go with the minimum that payers pay.
Okay, so Jen's gonna make it. Yeah, fine.
I'm gonna ask this question. I'm not sure if this is the place to address it, but I'm gonna just ask it here because then we can address it elsewhere if need be, but it says the board may, I'm talking about the language too at the bottom. Maybe you went to the next page already. No, wait, you're at the top
I
of the.
did when I'm looking at.
I'm sorry, okay, just because I didn't want people to get confused, it's the language about establishing it delivered outside a hospital. There, yeah. It says setting the amounts that health insurers must pay. And I know that AHS does the reference-based pricing for Medicaid. But I'm wondering how do we make there be consistency because later in the bill if we choose to accept the language about the correction system, that is going to be an interesting situation because Medicaid soon, unless it gets cut, is going to start. They're going to start being eligible, I think, 3 months before release for Medicaid. They're not eligible for private insurance, but if the state moves towards providing care for people when they're incarcerated before the Medicaid kicks in, who would then set those amounts? Or how would that be financed? And maybe it's addressed by that committee, comes back with recommendations about that piece, but I'm just seeing a gap there, if that makes sense.
Yeah, I don't know that we can address that yet. We're gonna be just starting on the reference-based pricing. So it's gonna be a while before they get to other healthcare professionals, I think, so we'll have
Yeah,
time.
maybe we could just think about it in the other section, like in that language that they're considering it, because I'm just thinking ahead, that's all.
Yep.
Right.
But yes, we are sort of, we're back to this in the intro language, if we talk about the minimum amounts that I think here and elsewhere that health insurers can pay. We're back to this idea of health insurers. Maybe that's okay for now because we're kind of talking about the universe that isn't Medicaid and Medicare. And it does include self-funded to the extent we can.
Yes, and I think what we're trying to get at here is sort of the reallocation of resources across the system. So hospitals, maximum what they could charge, but that the board may consider in a future date what the minimum
Yeah.
outside of a hospital that an insurer will pay. And that gets to, the idea of rate parity in a way, somewhat of that. I'm gonna let Mike speak really briefly and then we're gonna move on.
There's a hand up.
Okay,
I'm just gonna have one of our experts come in if they could zoom in if you want to ask. I think they'd be better at
Okay.
the way of answering
Can they
questions.
just hang out on
Yes.
Zoom? Great,
Exactly.
perfect.
I'm not sure I think the point that Bi-State just said about not conflicting with Bi-State is an interesting one that I think is worth having the board entertain how to deal with. That I don't think we can figure out here and now. But I am very, by saying what insurers can pay, and we are back into the world of what we can regulate and what we can't regulate. And I don't think anybody here wants to be saying Medicare Advantage can, what Medicare Advantage does to our providers. And we would be ripping those Medicare Advantage off to be able to underpay providers the way that they do. And I think we'd be significantly diminishing the board's ability to have an impact, albeit further down the road. Right thing to do is focus on hospitals now, on non-hospital providers. So I personally would stay with the same methodology around what providers can charge. But I want to also recognize what Bi-State just said and recognize there may need to be some thought about how to apply this to that case.
Yeah, it does seem challenging to try to, the idea of setting maximum amounts that primary care providers can accept doesn't really work if you're trying to make sure they're getting paid a higher amount.
Put that maximum out, like you might say, we want to supercharge primary care, and so we're going to set the.
Yeah, but that's a maximum. The maximum amount they can accept is $500 for a visit. The insurer is going to pay them less than that because that's a maximum. It's a maximum amount they can accept. I just don't think it gets you where you want to go. I don't know if there is a way to do it to get so that the providers have any basis on which they can say, sorry, we can only accept $500 for this visit Medicare Advantage. Just don't know that we get there.
And this is down the road and we're saying that the board may consider it. This is a may, not a shall. And
I can take out the reference to health insurers if people want. We could just say by setting the minimum amounts that must be paid.
okay, let's get rid of health insurance.
Paid or something.
And I am certain that if it gets to the point where the board considers this and wants to do this, they will go through the same machinations of coming up with reference-based pricing for services outside, and they would take all of this into consideration. Eli?
And then again, if we were going to do that language, I would ask for inclusion of Medicare and Medicaid, especially considering what the federal landscape looks like right now. We don't know what's coming.
I think Jen is going to make sure that we carve out
And
Medicare.
I want to look, because I think the definition,
Oh,
The air.
it is the, yeah, it's not that people are angry.
so I want, oh, you can see, I was gonna say, I want to note that Elena is now available to you. Just pulling up. Definition of health, and so the definition of health insurer for this chapter, put it up, specifically says it does not include Medicaid. So I would rather not, and we're talking, using the term Medicaid, I would rather not, or the term health insurer, I would rather not say it does not include Medicaid because it does not include Medicaid.
I agree.
So let's not.
Madam Speaker.
Madam Speaker.
Sorry.
Oh, please no.
Madam Chair.
Yes.
I just want to let you know, our expert Elena, who you are familiar with, is assuming that you know, okay, good. So she is ready for anything you might want.
Jen took the language down and there was Elena.
Good.
Yep. So here, it just so everyone can see it, is the definition in the Green Mountain Care Board chapter of health insurer. Any health insurance company, nonprofit, blah, 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 type of organization, to the extent permitted under federal law, any administrator of a health benefit plan offered by a public or private entity. Term does not include Medicaid or any other state healthcare assistance program financed in whole or in part through a federal program.
Okay, great. Concern address.
Okay,
Moving on.
moving on. So now we have a new section, section 3A. This is, so I just mentioned, but I try not to put these sections in as 3A, 11A, B, C, to try to keep the section numbers from the Senate bill the same so that when we are, if we end up conferencing or something and we're comparing side by side, the section numbers line up.
That's great.
So this is a new section 3A. This is adding the definition of hospital network here at the beginning of the subchapter on hospital budget review, so we don't have to put it in multiple places. So same definition we've seen elsewhere, just moved here to the beginning of 18 VSA chapter 221, subchapter 7.
Jenny, are you trying to have that?
I am trying to be showing you the language. Thank you. It was scrolling very nicely on my end. I just didn't have it up. Thank you.
What page is that?
This is on page 10. Section 3A. Yep.
All right, page 11.
Page 11, 18 VSA 9454. These are the hospital's duties with respect to hospital budget review. I'm just striking through all of this, but it looked scary when I was striking through all of it because some of it is existing language. So subsection A is just coming out of the bill because we got rid of all of the changes we were going to make to it. So this whole page will just disappear from your next draft. All right, so that was it. No change. So the only actual change in 18 VSA 9454 that this bill makes is to require hospitals to submit information as directed by the board in order to maximize hospital budget standardization and allow the board to make comparisons. Section 5 is the hospital budget review statute. So first in the reference and just throughout the bill, anywhere we talked about the statewide healthcare delivery plan, it became the statewide healthcare delivery strategic plan. Stop pointing it out. You took out that requirement that the board exclude revenue derived from primary care, mental health care, and substance use disorder treatment services when determining a hospital's net patient revenue and any cost of care targets. And I renumbered the remaining renumbered subdivisions accordingly. Just a little, I felt like this was supposed to be clinical leadership, not clinic. So I made that change on page 14. Now we're on page 15. Individual hospital budgets established under this section shall, again, strategic. All right, now we have promote efficient and economic operation of the hospital, and then new language. And if a hospital is, and I think we talked about affiliated with, or maybe the language that was provided was part of a hospital network, and I changed it to affiliated with. Hopefully that works. Let me so I can see Elena again. Ensure that hospital spending on the hospital network's operations is consistent with the principles for healthcare reform in section 9371 and the statewide healthcare delivery strategic plan once established. Next page. And we're in D, and we just got rid of the whole piece on starting to do global hospital budgets. Kristen, I'm going to let Mari in, or you can let Mari in. And hospital healthcare delivery strategic plan. It wasn't entirely clear where you ended up on this because there was a lot of conversation about it. This is in the, we were calling reverse CON, and where notice has to go. Did you want notice to go to the communities within the affected hospital service area? We was talking about not adding the public, but maybe including this language. So I put it in here for you to discuss. Because I wasn't clear where you landed.
Really, really don't want to go down this road again.
No.
What do you even have to have that service area? That could be anywhere.
What's a hospital service area is a defined term.
She was in here when it came to.
Lori, I really would love your suggestion on this. I really would.
I mean, yes, I think communities should be notified, and I think it's going to happen anyway. And if we say communities within the effect, like, what does that even mean? You know, so, yeah. I mean, all
right.
It's very
Shall
broad.
it come out?
Okay, I know. Leslie, go ahead.
Well, sometimes it's very specific, right? You close primary care in Bells Falls. Now, that wasn't done by hospitals, so.
Yeah, this is
interesting
hospitals.
problem.
Yep, this is hospital.
Yes.
And this is to comply with a budget order.
Yeah, forget it.
Yes. I hear you and
Yeah, it doesn't apply here.
but it just doesn't apply here.
And then there was question of whether 90 days was the right number of days, too long. There was bargaining. Where things ended up.
I am. Was there a grand bargain made?
I think there was
Somewhere between 15 and
Yeah.
90. I believe it was.
Devin Green from Vaz, we would suggest 45, again, just going off of 90 days is the first quarter of 1 year hospital budget. These budgets come out on the first day. Of the
So
first
the
year.
healthcare advocate is amenable to 45.
45. Okay. Oh, is Topper amenable to 45?
I'm a member to that, but that's what I want people to consider is, when the hospital does this, and we talked about this, the Department of Labor has to be notified.
Only if it affects a certain number of employees.
Yeah, well, the hospital won't meet that. either.
Well, it's not, in hospital, it's reducing or eliminating a service.
I mean, if they decide to
All I want to do is just remind people, that's all.
reduce services in phlebotomy.
So 45, did I hear 45?
45.
All right, 45 days. All right. Strategic plan.
Yes.
I agree with you, Madam Chair.
On the
So I
45.
want to make sure that you understand that.
I do.
Because I just came from a committee that told me they loved me and I got ding ding and I was out of there.
What committee was that?
So,
Okay.
Section 6. Now we are on to the hospital networks. So I deleted the definition of hospital network because it moved to the beginning of the subchapter, so it applies to this section as well. Now we have the board may review and evaluate the structure of a hospital network. And then in C, the board may recommend, and we took out or take appropriate action. So it would now say the board may recommend any action it deems necessary to correct any aspect of the structure of a hospital network, but it does not have the authority to take action.
Great.
All right. And then removed reference to appeal because they're not taking any action. Okay. Now we have healthcare contracts. I restored the language on allowing a contracting entity to require a reasonable confidentiality agreement and just made that subdivision 1, and subdivision 2 is upon request, the contracting entity or provider must provide an unredacted copy of a healthcare contract to DFR or the Vermont Care Board or both. Okay, now we are up to the sections on the statewide healthcare delivery strategic plan, the healthcare delivery advisory committee, and the comprehensive primary healthcare steering committee.
And can I just really quickly, since this is a good break, I'm gonna update the committee. We're gonna take a break at 3 o'clock. Okay? Jen's gotta run off to come off for a minute. So if everybody can make it to power through till 3.
Can I just ask one quick question?
Yes, of course.
So because when I was reading all of this all weekend, the steering committee is not formed yet, correct?
Not formed, we're gonna get to that.
Okay,
Yeah, we're getting there. That's coming.
thank you.
All right, so we have the plans. We have the Agency of Human Services in collaboration with all the people who were on there before, and the Comprehensive Primary Healthcare Steering Committee established pursuant to, oh, it should actually say section 97, section 710. We're in Title 18. Okay, and other interested stakeholders. Going to lead development of this strategic plan. The plan shall. All right, so now we get into a lot of people's suggestions. And I want you to just keep in mind whether I think some of them overlap and there may be some duplication, and so we may need to combine or prioritize. So the plan shall align with the principles for healthcare reform. Also, we can change the order of things if you want. I tried to put them in an order that seemed somewhat logical. So Representative Donahue wanted to add identify existing services as well as promoting access to services. So identify existing services and promote access. And I moved across Vermont up here, across Vermont to high quality, cost effective acute care, primary care, including primary mental health services, chronic care, long-term care, substance use disorder treatment services, emergency medical services, non-emergency medical services, non-medical services and supports, and hospital-based, independent, and community-based services, period. And that combines 3 and with 2 moves across Vermont up. All right, then we have, so it shall define, so we're getting into several VPQHC suggestions. Define a shared vision and shared goals and objectives for improving access to and the quality, efficiency, and affordability of healthcare services in Vermont, including benchmarks for evaluating progress. I don't know if we want people to stop if they have comments or go through. Establish performance metrics and accountability measures to track system-wide progress, promote transparency, and support continuous improvement. 5, provide a phased implementation timeline with milestones and regular reporting to ensure adaptability as needs evolve. They had a slightly different wording there, but identify the resources, infrastructure, and support needed to achieve established targets, which will ensure the feasibility and sustainability of implementation. Number 7, and my note here on this one is, does this belong in the plan itself or as a separate report? Incorporate an evaluation framework using a results-based accountability approach to assess both the effectiveness of plan development and implementation and the plan's overall impact. The evaluation shall include identifying what was accomplished, how well it was executed, and the specific benefit or the benefits to specific cohorts within Vermont's healthcare system. Said it's based on VPQHC, but I wasn't sure if it
I agree that
it's a little self-referential, so I thought maybe.
I agree though that it doesn't belong in the plan, it belongs in the reports.
But in which case it will be a question of who's reporting and when.
Okay, so what part of that?
Should it be incorporated into AHS's reports?
I have to step up to pick up a kid, but I have a whole list that I'm gonna ask Lori to walk through of my comments on this, and I think that one is one of them, but I have to go.
Okay.
And I think that one is one, and VPQ weighed in on this, and I want to include their feedback. So Lori, it's with Lori. I don't know if you want to walk through the rest of them and then do it at once. That's what I'm saying.
Okay,
So
let's walk through this section
Okay,
and
this
then.
next one is the one from Representative Rebecca. And I thought maybe it could be combined with another one. So that's a thought, promote accountability and continuous quality improvement across Vermont's healthcare system through the use of data, scientifically grounded methods, and high quality performance metrics to evaluate effectiveness and inform decision-making.
Are you thinking that number 8 is duplicated with?
Well, I think
4
there's some,
and-
this concept of performance metrics and accountability measures to track system-wide progress, promote transparency and support continuous improvement. There was definitely some around quality improvement and promoting accountability, performance metrics. There was a lot of similar language.
Lori.
I'll just read what Daisy sent, even though she's still sitting here. That 8.4 and 8, section 4 and section 8, that the revised language submitted by her and Mari for 8 could effectively replace the language of 4. Is that what you're saying?
Yeah, I think I wasn't sure there was enough difference going on between those that they couldn't either be combined or, keep one and eliminate the other, but I will let the committee decide what you want to do. But I did have the same thing. Now, there's still more. Do you want to keep going through all the rest?
Can we keep going? And then, yes, please, let's keep going.
All right, provide annual targets for the total cost of care across Vermont's healthcare system, and we took out the language about reasonable annual cost growth rates and excluding certain revenue from hospital total cost of care targets. There was a question from our editors, which is why I added this word on, but I wanted to get the committee's take. So the plan shall also establish targets for the percentages of overall healthcare spending that should reflect spending on primary care services, including mental health services. And is preventive services a separate target, or is that supposed to be part of primary care? I know sometimes there is some overlap, some differences between primary and preventive.
Oh, I never think of preventive as primary
Okay, then we'll leave it separate.
or primary as preventive. It's a part of it.
Yes, but is one fully subsumed by the other? Is preventive care a type of primary care, or is there like the Venn diagram with some overlap?
What's a colonoscopy?
Preventive.
Preventive.
Unless
Is
you have a
primary
problem.
care? No, it's
Okay.
preventive
So
care.
I
It's
would-
not primary.
Venn diagram.
Venn diagram, some overlap. Okay, thanks. All right, so we will say,
Because public health is also
Yeah.
preventive,
right,
but not primary.
okay. And those targets shall be aligned with the total cost of care targets. I'll let Representative Rebecca Lynn just pops up on mine, so I see them all right. All right, and then we've got renumbering here. This is the list of the build on data and information from a variety of sources, including, so this is also adding the 2020, so these are the 2 recommendations from the Vermont Medical Society. The 2020 report determining the portion of healthcare spending in Vermont that is allocated to primary care submitted to the General Assembly by the Green Mountain Care Board and DEBA in accordance with 2019 Action Resolves number 17, section 2, and the 2024 report on blueprint for health payments to patient-centered medical homes submitted to the General Assembly by AHS in accordance with 2023 Action Resolves number 51, section 5, and such additional sources of data information as, and then this is the cleanup, should lead with the agency since they're in charge and other stakeholders deem appropriate. Then we get into the things that it should identify. Maybe should we go through to the end of this and then we'll come back to the beginning and look at people input. Identify gaps in care. Here's why I added Representative Donahue's, including disparities in access resulting from geographic or demographic factors or health status, as well as, and then this is where we had gaps in access to care. And then I had said, as well as circumstances in which service closures or consolidations could result in improvements. BPQHC wanted to add or have negative results. My concern was that that is sort of what the assumption is. And so I changed it a little bit for your consideration to say, as well as unnecessary duplication of services, including circumstances in which service closures or consolidations may result in improvements in quality, access, and affordability. So hopefully that sort of defines a little bit more where that might be a plus.
Good.
Opportunities to reduce administrative burdens. And so I changed this around a bit to accommodate the addition from BMS. So this would now say, such as simplifying certain complexities in contracting and payment terms, streamlining methods of data entry and clinical information sharing, and eliminating or combining duplicative quality reporting requirements. I had to propose solutions rather than just complain about the problems. Hopefully that. Then we have state, federal, and other barriers. Then we have some more from various folks. So opportunities to improve the quality of care across the healthcare delivery system. Identify, that was VPQ from Representative Donahue, priorities and steps for achieving the goals of the plan. Representative Donahue, barriers to adequate mental health and substance use disorder treatment services resulting from a lack of parity in reimbursement rates. From Representative Chena, opportunities to integrate healthcare services for individuals in the custody of the Department of Corrections as part of Vermont's healthcare delivery system, including through expanded use of telehealth. Some more from VPQHC, enhancements in quality reporting and data collection to provide a more current and accurate picture of the quality of healthcare delivery across Vermont. Systems to ensure that reported data is shared with and is accessible to the healthcare professionals who are providing care, enabling them to track performance and inform improvement efforts, and exemplars of high quality care to stimulate best practice dissemination and strengthen Vermont's learning health system. I took out the specific directions on who contributes what and streamlined the process language. So it just has on or before January 15th. You change the date to 2027. The agency shall, I've said provide, as opposed to present, provide the plan to the House committees on, since we don't have the timing of when they're compiling it or preparing it. So they'll provide it to this committee down the hall and downstairs. And the agency shall prepare an updated plan every 2 years and provide it to the General Assembly on or before December 1st of every other year, beginning on December 1st, 2028.
Okay.
There's your new plan.
There's a lot in that.
There's a lot.
And I can see, I actually can see a lot of duplication as we're rolling through it.
Yes.
Lori, do you have?
I can just read you what she just sent me.
Okay.
So number 7.
Okay.
This could be removed from the section. The RBA framework component could be included in the reports. So I think we just said that.
Yep.
Okay. And then the other one in this section is that 4 and 8 so 8 could effectively replace the current language in 4.
Um. What about further down? In
Plug in my computer, which is fine.
the. Okay, yeah, so, no, I was gonna say, is everyone in favor of incorporating either 7, replacing 7 with 4 or 4 with 7, which?
8, 4 and 8.
4 and 8, sorry. Is there anything missing out of 4 that's not in 8?
Can you show us 4, Jen?
Yep.
I think, so I don't know which way we're going here, but in 4, it's to track system-wide progress, and we don't have that in 8.
I mean, it is you're right, it is across the system, healthcare system.
Oh, across the last.
Can we talk about this in general?
Yeah, before we pick it apart. Leslie, do you have comments on it in general?
Well, in general, yeah, I'm finding that what we measure is what matters. And that thinking about, I'm finding this really inaccessible, but it's because it's so very specific down to, like, whatever. And I'm wondering if we could kind of think about it as domains. Could we think about it as strength in primary care and prevention? Can we think about shift care out of hospitals? We're not thinking about quality in hospitals, and where is that getting measured? I'm just finding this really vague and not helping direct the work. But that's my experience, that's my impression from my experience in this.
I'm not interested in telling them exactly what it is that they have to measure and what we think is important to measure. I'm interested in setting up just bullets of it shall include things like this.
Well, then I think it should be all condensed, because we are telling them a lot in all these different A through H is that what they're gonna do. I'm not seeing a really great distinction between rural and urban. There's just different places in our state that we need measures to compare.
I identify existing services and promote access across Vermont. So to me, that gets into looking at all areas of Vermont.
That seems very vague to me. I mean, I'm getting that I'm not agreed with, but I could use more structure using quality improvement science, and I'm not seeing that here.
Madam Chair?
Yes, I hear you. Hold on one second. I'm just thinking there was a report on rural healthcare. Should that be one of the things that is included in the reports that they should be looking at? That we just listed all those reports.
People who.
Madam Chair, it might be helpful because there is no measurement for quality and there is no measurement for access in the state. Yeah, at least not in the terms that I think that you're referring to. There is 2 positions in the budget right now. The Green Mountain Care Board as part of the bigger plan would be to include a quality and an access person. So.
Because we do a lot about costs, but we're not doing a lot about quality. It's vague. And what is quality? And I think that we should, I mean, I'm good with domains. I'm good with, but, and I don't know why, and I'm seeing a lot
I
of.
don't know what domains means.
A domain is a certain area, an area of care, like hospital quality. Yeah, or a domain would be shift care out of hospitals. I mean, that's, Act 166, Act 167, shift care out of hospitals. We need to measure that stuff. We need to measure what's in Act 167, and I'm finding this very vague.
We're asking them that the plan shall promote access across Vermont. So that means everywhere in Vermont. That's accessibility. Access across Vermont. High quality. We want them to look at quality, cost effective in all of these things. I'm not quite certain why we have to start spelling out the particulars. When we're asking them, we're looking at accessibility, quality, and cost effectiveness.
I've got my hand up.
Mari.
Jen, sorry to do this to you. Can you go to 4 again? So I think we need both 4 and 8 or condense them. And I disagree that it's too vague. Continuous quality improvement is a very specific science. So we're asking them to use that science, even though we're not spelling out exactly how.
Thank you. Lori, I'm sorry, did you have
It's
anything?
okay. I wanted to answer your question one on the Rural Healthcare Task Force. I personally think we have done most of that, and it did not really talk about quality in that. It talked more about like scholarships and telehealth and all of that type of stuff. So, I mean, I don't care if we add it, but I don't think we need to add it to the list of things that they're looking at.
I was thinking more about the list where we were asking them in developing of the plan, they should
Yeah.
reference back to stuff. And I remember the Rural Health Task Force had a lot of, here's what we have now, here are who's retiring, here are areas in the state where it's particularly vulnerable. So maybe not looking at that one report around
Yeah.
the quality piece, but being able to, we should ask
I
them
mean,
to
we should-
reference it
We
back
can put
to.
it in. I just think it's old.
Okay.
Because it was
It's
before
old.
COVID.
Of course it's old.
And I would also say, I think this needs to be condensed. It could be condensed a little bit. I do think it gets to quality, but what we could do potentially is establish, so on 4, I actually think we can combine 3 and 4, but on 4, establish performance metrics and accountability measures to track system-wide progress, promote transparency. We could also say, and on quality measures as defined by the plan or something like that, to just make sure that we are tracking quality measures. That's maybe one thing we're missing. But it is a lot, so maybe it's in there and I'm just not seeing it.
Well, I mean, it's certainly down here in 8.
It's in 8.
Quality improvement.
I mean, to me, 8 incorporates all of 4 and then includes the quality measures.
Just
Keep going, Lauren.
So I think 8, if we're gonna use 8, which is fine, I think it does include it. I think somewhere it needs to say, that like, there are quality measure metrics. Right, so it just says promote accountability and continuous quality improvement. Well, how are we
Keep going.
defining
Keep going.
across Vermont through the use of data? But what are the metrics?
And high quality
Quality
performance.
performance metrics.
What are they?
Not what are they? I don't want to put what are they in there. I don't think I agree with the chair. We shouldn't put it in there. But I feel like in 4, we're establishing metrics. And then in 8, we're measuring the metrics.
How about 8, promote accountability and establish high quality performance metrics.
Can I work on
Yeah.
language and present it at 3?
Yeah.
Whenever we come back.
That would be great. Okay.
I have my hand up. I'm not sure if you can see me.
Sorry, go ahead, Daisy.
I just want to remind the committee that I worked on this language with VPQHC, who has been doing this for a long time. And any changes that we make, I want to be able to run by them and make sure that it is consistent with whatever their practice is and their plan was, right? So if we modify it, does it still meet what they had envisioned for the flow of this work?
The language that you have in number 8 that has your name on it, was that developed in collaboration with VPQHC?
They did advise me on it.
Okay, so their number 4 was them coming in before they advised you on it.
I'm sorry, I'm driving, so I can't see it.
Their number 4, which is establish performance metrics and accountability measures to track system-wide progress, promote transparency, and support continuous improvement. That was given to us prior to you working with them on number 8.
I don't think it was.
Okay, well, they duplicate each other, so I would like to get this down to 1.
Yeah, I think that would be fantastic. I totally support that.
Okay, so how do we take number 8 and address Lori's concern because she wants to make it clear that it needs to be looking at high quality metrics, that to work on the language that will say the exact same thing, but say.
I found personally, it might not meet Leslie's answer, but I think number 3 gets to it and then scratch 4. Because it says an affordable, including benchmarks for evaluating progress. So that means they're going to create benchmarks for quality, efficiency, and affordability.
Okay, so you're just in favor of striking 4. So can everybody agree we're gonna just strike 4? Okay, striking 4.
And this will be my last point.
Leave an 8.
I'm still struggling with the vague. I understand you don't want specific measures, and I get that. But this is what my fear is, that we won't end up measuring what we need in order to move the system forward. And there are very established in the literature, performance measure, quality measures that can evaluate a system.
I think we have in here evidence-based.
We do.
We do.
It could be 12, and who gets to pick? I'm done. I'm just not,
No,
I'm having difficulty with the vagueness of this language. And now, it may be totally appropriate for this bill. It may be rule where we could maybe have some opportunity to be more specific. I don't know, but I would feel better if there was a little more.
I am
Our system as a whole.
I am not putting specifics into statute.
I get that.
Those quality measures could change a year from now based upon evidence. I'm not gonna put the statute, and I will remind you that there is a steering committee that advises this, and that steering committee is made up of many, many different who it is up to them to ensure that this plan is being developed with evidence-based quality measures.
Thank you for listening.
Okay, I really do, I'm not dismissing you, but I do feel like your concerns are being addressed. And they will be addressed.
And we will know when we have the.
And that we have the language in here to ensure that that happens. Lori.
And 5 go into 7 and also go into the reports. So provide a phased implementation timeline with milestones and regular reporting to ensure adaptability as needs evolve.
Shouldn't the most important part of the strategic plan be the timeline of it? I mean, remember, this is the plan.
And again, this is just an effort to make this shorter, but we could say including benchmarks and a timeline. I'm not gonna, that's fine. Let's keep it. It goes long anyway, so give you a couple more things.
I do personally think 6 should be above 5 though. First identify the resources, infrastructure and support needed to establish it, and then tell us what the implementation timeline to achieve it is.
That makes sense, people?
Does that make sense? Okay. 6 becomes 5, 5 becomes 6.
Actually.
Actually, it's all going, okay, all right,
Yeah.
okay. Yes, I know. All right.
All right, so 7 gets moved out and becomes standalone. Do you want this sort of embedded in their annual report, the agency's annual report?
I believe it should be in the agency.
Report is going to be an evaluation framework.
No, it's going to include that. The report's already in a different section back at the end.
Yeah.
And we're just gonna take this and we're gonna say this needs to be included also in the report. Because this is more of a reporting piece than a plan piece. Okay,
Yeah, I'm okay.
okay.
I just want to make sure
It's
that
not gonna go, it's gonna be,
there's two things.
it'll change a little bit.
Periodic monitoring. What was it, monthly?
Yeah, we've got,
The month is separate.
that's,
I know it's separate, but we're gonna have that plus an overall evaluation.
yes, and a yearly,
You're gonna have an annual report on kind of how all of this is going. You're gonna have every other year updates on the plan. You're gonna have in the short term monthly planning, because it came from Representative Houghton's language, monthly updates on how various short term things are going.
Right.
You are gonna have reports.
we're gonna have lots of reports. Okay, so moving on.
Right. There anything?
Is there anything else in here in this list?
Mm,
We are keeping 8 as it is, or we're gonna work on, Lori, you were good because you
Gonna-
covered, okay, 8's thing.
You've got a hand up.
Daisy,
Is that a legacy hand?
Daisy, do you have a?
Yeah, was taking myself off mute. Did you already go over Donahue's additions?
No, except for, I think just the one at the very beginning about identifying existing services. The others are in the identify list. This is the plan shall list.
This is the plan.
Next step is the plan shall identify list.
We haven't gotten there yet.
Okay,
There's no plan may list, right?
I'll speak up when you get there.
Okay.
All right,
9,
we have that whole long list. Oh, 9. Yep, total cost of care targets.
again, the editors edit.
They asked a question, yes, and so to be clear, that was separate. They asked if it should say including mental health services and preventive care services or. 10 is building on data and information from various things, and I can certainly add another one on the rural. I'll look up the name again, rural healthcare.
If it's really that old, then,
it's before COVID.
yeah, I mean, we've got stuff in here from 2019.
I mean, doesn't hurt it to add it, but don't have to.
They'll look at everything.
So add it, don't add it?
No, don't add it.
I feel like it informed things that have come since, anyway, like the Act 167.
Okay, and then we have, here's the identify list. So the plan shall identify, and this is where we get into some of Representative Donahue's. So gaps in care, and she suggested including disparities in access resulting from geographic or demographic factors or health status.
It gets to accessibility. Can't remember what the 3 were.
Oh, and then as well as unnecessary duplication of services, including circumstances where service closures or consolidations can result in improvements in quality, access, and affordability. B, the opportunities to reduce administrative burdens. New language and proactive language to go with BMS's proposal.
Okay,
Barriers in C and how we can remove or mitigate them. D, opportunities to improve the quality of care across the healthcare delivery system.
Ryan?
Like a teaser, that I think that D could include F and G if we needed to condense things, if we need to. I don't know if we need to, but I'm just putting it out there because it's such a broad statement. But I wouldn't want to lose the clarity of F and G, so I don't want to skip ahead, but I'm just saying like that, I think D is really important and it kind of covers some of what's coming ahead. If we need to condense.
Yes, I wasn't sure if the breadth of this one meant it should go higher up in the list. It does sort of stand out in its brevity and breadth, but.
Tucker?
Yeah, on that same page, 25, can we just go back to B for a minute? Because we're talking about reducing administrative burdens. So should we add in there the appeals process?
I don't even.
Appeals process for what?
Well, we're changing it so that they go directly to the Supreme Court.
Oh. No, that's
separate.
That's
It's
separate.
not an administrative burden on the delivery of healthcare. That's a regulatory. It's a regulatory appeals process. I don't think it belongs in here. If you want.
It's a different kind of
to
administrative
looking
burden.
at it,
Yeah, it's like a different kind of administrative burden.
it's an administrative process.
Yes.
People may disagree about which process they prefer, but it's
Yeah.
nothing wrong with it.
Oh, I see, you're saying, I get it, it's like, okay.
Okay. So I don't know if you want to make any changes around quality of care or move it up or just leave it right
Where
there.
would you move it?
I'd like to the beginning of your list of identifying or after gaps, like, I don't know. Nope, just leave it okay.
I think it'd be good is the first one. because
I think it would be, I think it would be good as, at the first one. Okay, well, we can talk about this as we go through it, but I have some thoughts around a lot of these things, but let's keep going.
Okay, priorities and steps for achieving the goals of the plan. From Representative Donahue. And I don't know if that goes sort of along with the phased implementation timeline from the plan shall. Or,
I have a hard time with the language of this, like, is it saying that we want like a prioritized list of steps to achieve the goals? Is that what it means? Priorities in steps for achieving, does that mean like?
this was the language that was provided.
Yeah,
And I will say it was provided, I think, based on the version of the bill that passed the Senate. So it was before a lot more was added in.
because when people say priorities in steps, like, that's what I'm trying to understand what they mean by that, like.
I think that it's basically saying, okay, well, here's all of our goals. Now we want you to prioritize the steps that we need to take to get to the goals. Who comes first?
Yeah, that's kind of what I was thinking it meant.
That's what I think it means.
Yeah.
Isn't that the timeline that is established?
Can you refresh my memory, Jen? What are we doing here in these A, B, C, D, E, Fs?
Plan shall identify.
Okay, we're identifying.
Identify. Just
Okay.
identifying. That is your lead into every single one of these. Identify opportunities, identify priorities, identify barriers.
Okay, so I'm going to make a suggestion because a lot of these are suggestive.
Yeah.
And I'm going to make a request that we get rid of the suggestion, you know, the such as, or the kind of things like this. And we just keep to what it should be doing. Just very simple terms. Opportunities to improve the quality of healthcare across priorities in the steps for achieving the goals. Barriers to adequate mental health and substance use disorder treatment services. Opportunities to integrate individuals in the custody. I'm
We don't need to telehealth, is what you're
we
saying.
don't need the including
Yeah, yeah,
through the,
that'll
or the, frankly, the, and you know, I love administrative burdens, but you know, the such as contracting payment terms, streamlining data. I think it should just be, we want them to look at these things. We want them to identify these things.
Okay, so
Let them identify.
can we go back to 6 then and have you tell me what to get rid of?
Yes.
So if they're gonna identify, do you want everything gone after gaps in access to care?
Gaps in, no, because I sort of am thinking that those things are how you come up with gaps in care. So I'm okay with leaving that.
How much of it? All of it?
All of A.
Okay.
B.
You just want opportunities to reduce administrative burdens?
Yes.
Put on, okay. And are people gonna speak up if otherwise? I'm
There's a
just-
new
Yeah,
A,
if
right?
somebody, yeah, if somebody, and there's a new A.
Yeah, T, yes, T is the new A.
Relettering, to reletter them.
Yep. C, okay.
Good.
B, that would become A. Okay. E,
He's fine.
Yep.
F, you want
Barriers to adequate
after services?
after
Exactly.
services.
Exactly.
Um,
Then when I suggested
I want
we could cut the including through expanded use of telehealth off, and I would be fine with it. If,
Great.
yeah, it's because,
Thank you.
yeah, yeah,
Thank you,
I'm
Brian.
suggesting cutting my own.
Thank you.
Right, so
Yeah.
no one else has to do it.
Yes. Daisy, did you want to say something about F, keeping in mind that we have just gotten rid of resulting from a lack of parity in reimbursements rates?
Oh, that's what I was gonna suggest. Thank you very much.
Great.
Underneath their expanded use.
What's next? I love spring cleaning. Let's just keep doing this, trimming things out.
All right, H.
Enhancements in quality reporting and data collection.
Period.
Well, no, I'm kind of good. I'm kind of good with that because
Okay.
we're telling them what. Accessible health and providing care. I like,
I don't know, I don't like enabling
I'm
people, but I'm
I'm-
okay with this.
I'm doing a lot of I statements here, and I mean, if anyone, please chime in. And then J. Leslie, did you want to chime in?
Well, I'm not chiming in on the letter, so you may want to go through the letters and then I'll chime in.
Have you?
That was it. That was the end of the letters.
On any of the letters.
So I'm not chiming in on the letters. I'd like to comment on something else when you're ready.
Okay, did you want to chime in on all the things that we just cut? These such as.
No, not that. I might as well say what I'm thinking.
Let's wait until we get to a
Let me know when you're
place
ready.
when you're.
Because we can move on from this then.
You're all down through J now, right?
We're all done through J.
Madam Chair, you have a hand.
Where?
I do.
Representative Portis. Oh, you can't see.
Oh, I
No,
can't
we
see.
can't.
I'm sorry, Mari, I can't see you. Would you like?
Yeah. What does this mean, Jay?
The exemplar one?
Yep.
I see it as me, I mean, I'm not the witness, but as a healthcare provider, who does like therapy and stuff, I see that as like them putting in this report some specific examples of how you can provide care at high quality so that it teaches other providers. That's how I saw it, but I could be wrong if that's what they meant.
Right, I think it's.
I saw it as best practices.
Yes.
Yeah. Examples, though, like specific ones, so they're gonna give us, they might say like housing first, and here's an example, or they might say, what's the contingency management, and here's an example.
Here's
I'm
a
just saying-
state that does it really
Exactly,
well,
yeah.
and this is how they're doing it really
Yeah,
well.
exactly.
What is the
You're
Vermont
who's doing it
learning
well, the whole
health
state should be doing that.
system?
Wait, can we let Mari talk?
What is Vermont's learning health system? I just don't think we need this.
That was a VP.
that too. Isn't that what Vital's supposed to be doing?
I'm fine with removing J. Does anyone want to keep J? Anyone in love with J?
Is it in here anywhere else?
Well, you know, quality improvement is.
Quality improvement.
I'm okay with removing it. I just want to look at the new A quickly to make sure it covers it. but it used to be the D, right? Can we just, would it, people be okay with the opportunities to improve quality of care, opportunities and example to improve, or adding examples in there, like a word somehow, so that it's covered by A? To improve quality of care and I don't know, providing examples of best practices, or. Because there isn't anything really talking about best practices in here, but if we could integrate it into another one, it would reduce.
So we could say something like opportunities to improve the quality of care across the healthcare delivery system, including exemplars of high quality care to stimulate best practice dissemination, period, and take.
Yeah, they don't need, all that needs to be in there, but
Period.
something, yeah.
If I may. Exemplars really isn't a process. That's very passive. We're just gonna show you something.
That's what we're doing here, though. We're identifying things.
But I think we need a process. I mean, and that's what I'm wondering about. And I'll wait once again.
There might be another
Well,
section.
that may be the part about stimulating best practice dissemination. I think dissemination is the activity.
I might do better than with that than exemplars.
I love the language that you said, Jen.
Yeah, thank you.
Quick, write it down.
No, I'm just, I mean, it's
Yeah.
mostly from here. It's just
Yeah.
combining it with.
And I would be fine with it being simpler, but you captured what I was suggesting, which is just move it into another one. But I think there's benefit to like looking at examples.
Definitely know Vermont's learning health system, since none of us know what that means. Okay,
Some of us might.
let's go.
So then we get to the dates, January
Wait, we were,
27,
oh, that's two. Okay, got it.
January 27, updated plan every 2 years, provided by December 1st of every other year, beginning December 1st, 2028. Which is before the 29, so that's the new General Assembly comes in. That's not the middle of the biennium. I think I was thinking that was going to be the middle of the biennium. but not.
That's right.
Yeah.
Because the new one comes in January 29.
So maybe you wanted to begin.
I thought it was going to begin on December 1st of 27. And then every year, every odd year thereafter.
This to them until December of 27 and not January 27?
Well, I just thought 27. So the next General Assembly will get, as soon as they get here, in their first
General
year.
Assembly will get here in, so that would have to be December 26 for the next General Assembly to get it, or this is, this.
No.
this-
Yeah. So this
Wanted it to get,
January
yep.
15th. Next General Assembly will get it. And then beginning December 1st of every odd year in 29.
In 29. So we'll say every other year still, but beginning in 2029. So there's a little,
So it's the beginning of every biennium.
Yeah.
Is that correct?
No,
this one will be in the middle.
in the middle.
So the people who already kind of know the lay of the land are coming back for the second year. And getting an updated.
The first report has to come, because we're gonna get an update next year. And then we want the next General Assembly, as soon as they get here, to get the report. But the report is best served by a committee that's been here for a year. So they will get it in the middle of each biennium.
Right, so it'll be December 29, because there'll be an election.
So the idea is that they would get oriented the first year and then get a report the second year, make changes. Okay, that makes sense.
Yes.
Sorry, I was talking. It makes sense now that the chair explained it, because I was worrying, but it makes sense, people get oriented, get the report, and then but then I just hope people take action and don't, I don't know, but the dilly-dally, or I'm trying to think of like a nice way to say it, but
Okay.
hem and
Okay,
haws,
so
I don't know.
we've reached the end of this section and it's about time for.
About time for you.
Stare. We've also had a comment from Representative Goldman that she was holding on to.
Okay. Do you want to flag it?
No, it's more philosophical and I think the train is left station.
Okay.
You can jump in front of it still and stop it.
Maybe that would work.
Okay, let's let Jen go. We'll take a break. It's possible Nolan will be back here, so we do need to talk to Nolan a little bit.
How long of a break is this? 5 minutes, 10, an hour?